Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Thank you, Dr. Isa, for the nice introduction. I would like to thank the MESTRO Society for the kind invitation to talk about the chemotherapy in advanced laryngeal cancer. Presenting like few numbers. This is from the cancer registry in Saudi Arabia. And just I'm giving that as an example, but I'm quite sure in the Middle East, we share like similar kind of distribution of these kind of cancers. If you look at the top ranked cancers in males and females, you don't see head and neck cancer among these. And the reason for that, at least in Saudi Arabia registry, that each of head and neck cancers are being labeled as a separate disease entity. For example, you have tongue cancer, you have mouth cancers, you have tonsil cancer, then you have oropharyngeal, hypopharyngeal, and all of these. But if we count all these numbers collectively, you can see that head and neck cancer represent like 7.5% of all cancer diagnoses in male patients and 4.3% of all female patients, averaging 5.9% together. So if we go back to the same top ranked cancers in males and females, you might see if we have all head and neck cancers collectively, it might rank number 3 in males and might rank number 6 or 7 in females. So it's not as we previously thought that they are rare types of tumors, but actually if we count all of these like head and neck cancers, they represent a good bulk of all cancer diagnoses in our region. You see this is the general algorithm for management of head and neck cancers. Very early stage, usually we go with single modality treatment, either surgical or radiation. Of course, in laryngeal cancer, we prefer radiation. Locally advanced, we might go for combined modality, including concurrent chemoradiation, plus minus surgical intervention. Of course, for metastatic and locally recurrent disease, for most cases will be chemotherapy or systemic therapy, and the goal is palliation. And of course, the overall prognosis is very guarded in advanced and metastatic stage cancers. When we talk about advanced cancer, metastatic, like head and neck cancers, including laryngeal cancer, we know that extreme protocol used to be the standard of care for more than a decade, from almost 2017 till 2019, when cetuximab was approved in the management as a first-line treatment in advanced and metastatic head and neck cancers, including laryngeal cancer. This kind of trial have tested the rule of addition of cetuximab to chemotherapy, which used to be platinum 5-FU, the standard of care before that time. So we see that addition of cetuximab has improved the overall survival, which is the primary endpoint, from 7.4 months to 10.1 months, with absolute difference of 2.7 months, which was statistically significant. You can see other parameters of efficacy, including progression-free survival, overall response rate, and disease control rate. All of them has improved significantly by adding cetuximab to chemotherapy. And this is why this chemotherapy plus cetuximab used to be the standard of care for a long time, until we had two large landmark studies. One of them is the KEYNOTE-048, substituting pembrolizumab for cetuximab. The other study is the TPX study, substituting docetaxel for 5-FU in comparison to the extreme protocol. Let's go with the first study, the KEYNOTE-048, comparing pembro as a single agent or pembro plus chemotherapy versus the extreme protocol, which is cetuximab plus chemotherapy. This is a three-arm study, the KEYNOTE-048, and you can see there is a single arm for pembrolizumab, single agent. There is another arm for pembro plus chemotherapy, and a third arm for cetuximab plus chemotherapy. Of course, in the pembro plus chemo, cetuximab plus chemo, the chemo was allowed for a total of 6 cycles. Then the chemotherapy will stop, and patient will be continued on pembrolizumab monotherapy or cetuximab monotherapy. And this is the patient characteristics and tumor characteristics. you can see the HPV percentage in oropharyngeal cancer was in the range of 20%. When we look at the PD-L1 positive population, if you consider CPS score more than 20, it was in the range of 40 to 45%. If you consider the PD-L1 score positivity at a score of 1 or more, it's going to be 85% of those patients were PD-L1 positive with a score of CPS 1 and more. So if you look at the Pembro alone in comparison to cetuximab plus chemotherapy, it was superior with regard to overall survival, talking about CPS score more than 1 or CPS score more than 20 or in the entire population. However, if you look at the entire population, you have to keep in mind that 85% of those people are PD-L1 positive. So probably the benefit here was mostly driven by the PD-L1 positive population. There was a numerical improvement. It was not statistically significant, but in CPS score 1 and more and 20 and more, it was statistically significant in favor of Pembro monotherapy as opposed to cetuximab plus chemotherapy. If you go to the Pembro plus chemotherapy versus cetuximab plus chemotherapy, it was positive in all populations, like including those with CPS score 1 and more, CPS score 20 and more, and in the entire population. All of them was significantly better in favor of Pembro plus chemo, so indicating that this kind of combination can be used regardless of the CPS score. Somebody might ask, what if we consider those patients with low CPS score or CPS score negative, like less than 1? You can see, if we consider CPS score less than 1, which is PD-L1 negative, you can see that extreme was better than Pembro. Okay, numerically better, was not statistically significant, but numerically was a little bit better. For the Pembro plus chemo versus extreme, there is no benefit in PD-L1 negative. However, you can use Pembro plus chemo if you prefer the toxicity profile of such a kind of combination. The same for the overall response rate. For Pembro versus extreme, you can see that the response rate was better for extreme, and this is mostly driven by the chemotherapy, because chemotherapy is the active agents that will give us a response. But if you look at Pembro plus chemo versus extreme, you don't see a big difference when we talk about overall response rate. This is the duration of response was extremely phenomenal in favor of pembrolizumab monotherapy versus extreme. You can see that duration of response was significantly better. Pembro plus chemo, also duration of response was better in favor for Pembro plus chemotherapy. When we talk about toxicity, you might imagine that expect that Pembro single agent was far less toxic in comparison to extreme, because there is no chemotherapy arm here. And the grade 3 to 5 toxicity was in the range of 17%, as opposed to almost 70% in the extreme protocol. While the Pembro plus chemo, there was no big difference with regard to toxicity profile, however, was not more toxic than extreme. You can see the grade 3 to 5 toxicity was in the range of 70% of both, because again, this is mostly driven by the chemotherapy. When we talk about toxicities of the pembrolizumab, was mostly immune-mediated toxicities, including dermatologic, endocrinopathies, mainly hypothyroidism, and GI toxicity in the form of diarrhea, and most of these toxicities are quite manageable. So as a conclusion of this landmark study, the Keynote-048, that pembrolizumab monotherapy has improved survival significantly in all PD-L1 positive, whether talking about CPS score of 1 and more or CPS score of 20 and more. However, in the PD-L1 negative population, pembrolizumab was not superior to extreme. For Pembro plus chemotherapy, it was superior with regard to PD-L1 positive, CPS score more than 1, CPS score more than 20, and in the entire population. So the Pembro plus chemotherapy might be used regardless of PD-L1 score testing. Let's go to the other study, which is the TPX study, which is another landmark study in the first-line setting. It was comparing TPX protocol versus Extreme. What they did exactly, they substitute docetaxel for 5-FU. The problem with 5-FU is an infusional 5-FU that will take 4 days of infusion. Here they use docetaxel instead of that. So it's going to be a combination of cisplatin, docetaxel plus cetuximab. In the Extreme protocol, it was cisplatin, 5-FU plus cetuximab. In the Extreme, they allowed for 6 cycles of chemotherapy. Then patient will go for maintenance, cetuximab. Here they allowed 4 cycles of chemotherapy plus cetuximab. Then patient will go cetuximab monotherapy. The Extreme protocol, they use weekly cetuximab. In the TPX protocol, they use every 2 weeks cetuximab. So if you look at the beginning, that the protocol of TPX is much more convenient in comparison to Extreme. The question now, is TPX chemotherapy as good as Extreme? This is what we need to find. The primary endpoint of the study was overall survival, secondary endpoint including response rate, progression-free survival, and also they consider quality of life and tolerability. With regard to overall survival, you see there is no difference, significant difference between the two. Numerically, it was better in favor of TPX. Median survival was 14.5 months for TPX and 13.4 months for the Extreme protocol. For progression-free survival, again, there is no major difference between the two. So you can conclude from an efficacy point of view, the two regimens might be equal and TPX regimen might be as good as Extreme. If you look at the toxicity, grade 3 and more toxicity was reported in 36% of the TPX protocol versus 51% in the Extreme protocol, which was significant, meaning that TPX significantly less toxic than Extreme protocol. And these are the most commonly reported toxicities: neutropenia, anemia, thrombocytopenia. So all of these toxicities were significantly less in TPX protocol, and also GI toxicities in the form of mucositis, vomiting, and nausea. All of them were significantly better in favor of TPX. Also, TPX was much better with regard to compliance because of less toxicity. And the maintenance, those patients who were be able to go for maintenance cetuximab were 52% in the Extreme protocol and 72% in the TPX, which was significantly better in favor of TPX. So the interesting finding of this study that it gave us another option, which is much more quite tolerable, less toxic than Extreme, with similar efficacy in comparison to the Extreme. So in the first line option now, we have the pembrolizumab as a monotherapy, we have pembro plus chemo, and we have the TPX regimen as a substitute for Extreme for those who are not candidate for pembrolizumab or immunotherapy in the first line setting. What about second line treatment? In general, we have the Checkmate 141 using nivolumab versus investigator choice chemotherapy. So they compared immunotherapy versus chemotherapy for those who failed first line chemotherapy or those who have relapsed quickly on a platinum-based concurrent chemoradiation within the first 6 months. So the patient had been randomized to use nivolumab versus standard chemotherapy at that time. Remember that those patients did not receive immunotherapy in the first line setting. And the primary endpoint was overall survival. You can see that nivolumab was superior. At 12 months, the overall survival rate was 34% versus 19.7%. At 18 months, it was 21.5% versus 8.3%, with a median survival of 7.7 months versus 5.1 months, with a hazard ratio of 0.71, which was significant in favor of nivolumab as opposed to chemotherapy. Another study is the Keynote 040 using pembrolizumab versus standard of care chemotherapy with a primary endpoint of overall survival. There was a numerical improvement at 12 months, the overall survival rate was 37% in favor of pembrolizumab versus 26.5% for standard chemotherapy with the hazard ratio 0.8. However, this kind of benefit was mostly restricted to those who have PD-L1 positive disease with TPS score more than 50%. You can see that at 12 months, the overall survival rate was 46.6% versus 25.8%, with a median survival of 11.6 months versus 7.9 months. And this is why the pembro approval in the second line was conditioned by doing PD-L1 testing using TPS score of 50% and more. So what is the treatment algorithm for advanced and metastatic head and neck cancer, including laryngeal cancer? These are the NCCN guidelines recommendation. You can see that pembro plus chemo and pembrolizumab were put as a preferred first-line options in these cases. They also put alternative extreme and the TPX protocol as alternative options. And of course, they included immunotherapy, nivolumab, and pembrolizumab in the second-line setting for those who haven't been treated with immunotherapy in the first-line setting. In my clinical practice, what I do in the first-line setting for those who have de novo metastatic disease or those who have a rapid relapse within 6 months of platinum-based concurrent chemoradiation, if they have a PD-L1 positive disease or CPS score more than 1, and those who represent 85% of all these advanced head and neck cancers, we use pembrolizumab as a monotherapy, especially for those who have CPS score more than 20, or alternatively, I can use pembrolizumab plus chemotherapy, especially if response rate is needed, if the patient was symptomatic or has a high volume of disease. On the other hand, the PD-L1 negative, and those represent 15% of head and neck cancer patients, we use TPX regimen, cisplatin, docetaxel, cetuximab. Alternatively, I might use pembrolizumab plus chemotherapy because if in the subgroup analysis, even PD-L1 negative patient, they get benefit from pembro plus chemotherapy, quite similar to the extreme protocol. What about second line treatment for those who still have residual cancer, post-concurrent chemoradiation, or those who has relapse within 6 months or who have failed first-line chemotherapy? In these patients, if immunotherapy was not used in first-line setting, I would consider using single-agent nivolumab or pembrolizumab if TPS score more than 50. If immunotherapy was used in the first-line setting, I would use other systemic chemotherapies, including cetuximab or single-agent chemotherapies that haven't been used in the first-line setting. And with that, I would conclude my talk, and thank you for your attention.
Thank you, Dr. Ahmed, for your nice presentation. I don't see any question in the chat. So at your institution, Dr. Ahmed, what's your preferred first-line chemotherapy for metastatic laryngeal cancer?
Yeah, as we said, if the patient was PD-L1 positive, namely CPS score more than 1, okay, I would prefer, in most head and neck cancer patients, including laryngeal cancer, most of them are symptomatic at the time of assessment. So most of the time, I consider using pembro plus chemotherapy for 6 cycles. Then I drop the chemotherapy. I continue pembro as a single agent. If patient has a very high score, like more than 20, the PD-L1 score, CPS score was more than 20, and patient is not symptomatic and doesn't have a high volume of disease, I may consider pembrolizumab as a monotherapy in these patients. In the case patient was PD-L1 negative, I prefer, to be honest with you, using cetuximab-based chemotherapy, cetuximab plus chemotherapy, leaving immunotherapy for later lines in the second-line setting and beyond.
And what's your preferred second-line immunotherapy after initial chemotherapy without immuno?
Most of the time, I use nivolumab. The reason for that, because it doesn't need any PD-L1 testing. So the patient, once they show disease progression, I immediately start nivolumab. I don't have to test for PD-L1 and to wait for the results. However, if nivolumab was not available and I'm forced to use pembrolizumab, I prefer to do PD-L1 testing. If TPS score more than 50, then pembrolizumab would be an option in these patients.
Thank you, Dr. Ahmed. I think we have one question in the chat also. Let's check. If you use a neoadjuvant chemotherapy, then followed by radiation, how many cycles you prefer?
In case of organ preservation, we use neoadjuvant chemotherapy. I usually prefer to use TPF chemotherapy in these patients, and usually I will go for a total of 3 cycles. However, I do the assessment after cycle number 2. After cycle number 2, I do the assessment. Usually we do MRI, usually we do a CT scan or PET scan to assess treatment response, to document that those patients are responding well to the neoadjuvant treatment.
And Dr. Ahmed, after a neoadjuvant, do you prefer to proceed with radiation alone, or do you prefer to give carbo radiation?
To be honest with you, yeah, the standard of care in our institution is to go with concurrent chemoradiation. Usually we use, as you correctly said, Dr. Isa, carboplatin-based to avoid the accumulative toxicity of cisplatin used in the induction chemotherapy.
Thank you, Dr. Ahmed, and for your nice